Okay, good morning, and thank you for the invitation to present this morning. I've been asked to provide a very short summary of the behavioral health workforce. So in the next 8 to 10 minutes or so, I'm going to talk a little bit about supply and demand and some thoughts on challenges and opportunities in workforce development for this population. This is probably not a surprise to many in the room, but the field of behavioral health is in the midst of a workforce crisis, and this is a declaration that was made by the Annapolis Coalition when they released a report in 2007 on the state of the behavioral health workforce. And there were many concerns cited in that report, some we've already heard about this morning, but in general, an increased demand for behavioral health services, some prompted by mental health parity legislation and healthcare reform. In general, we have too few workers to meet this demand, but it's not just a numbers issue. We also have a poorly distributed workforce, a lot of maldistribution, which I'll touch on in a minute. As we've heard about quite a bit this morning from the panel and from Dr. Leslie, there's a need for additional training, and I'll add one more example to that list that we've already started this morning. An increased emphasis on integrated care, team-based care, treatment of co-occurring disorders. We hear from the field loud and clear that many of our providers aren't being trained in how to deliver services in these types of team-based care models in their education and training programs. And in general, we have a lack of systematic workforce data collection in behavioral health, and you will see in a minute how that limits what we can say about supply and demand projections going forward. So first I want to just have us think about what we mean when we're saying the behavioral health workforce. We're broadly talking about folks who are involved in prevention or treatment of mental health and substance use disorders. If you look at the literature on the behavioral health workforce, you will by and large see a focus on what are considered the core licensed professionals that are listed here. We have more complete data on these professions, but they certainly don't represent the entirety of the behavioral health workforce. There are several other folks, and this is just an example, this is not meant to be an all-inclusive list, but folks like addiction counselors, peer providers, folks in support staff positions who are certainly providing very important services in behavioral health. This is not meant to imply that all folks in behavioral health are either licensed or certified. They're certainly not, but there are opportunities for licensure and certification for many behavioral health occupations. And we also don't want to forget about primary care providers, because in these areas that don't have behavioral health providers, primary care is really serving very much of a frontline role, regardless of whether they have specialized training in this area. So when we think about behavioral health workforce capacity, we're thinking about a very diverse set of occupations. So here's what we know about behavioral health workforce supply. I've chosen today to focus on Bureau of Labor Statistics data along with a few other sources. There are other sources of workforce data, licensure data, national sample survey information. The trick with workforce data is the data source that you choose will present different types of estimates. So it's a challenge with workforce planning. In this particular slide, we're again primarily focused on those core licensed professionals because that's what we have the best data on, aside from the psychiatric aides and technicians, which are that third bar down. This slide is showing a little over 912,000 workers in behavioral health in these occupations. I would love to be able to tell you today exactly how many of those are focused on children, youth, and families. We don't have data that's specific enough for me to give you that level of information. Instead, what I've tried to do is the green bars represent areas or occupational classifications that indicate some sort of focus on children and families, so child and family and school social workers and so on. The blue bars represent other types of occupations who certainly have some level of involvement in providing care to children, youth, and families, but we don't have the data to show exactly to what extent and how many. Of the data listed here, of the folks listed here, about 438,000 of that 912 or so thousand have some sort of child or family focus. I mentioned maldistribution previously. This is a map from HRSA's data warehouse. The blue shading indicates areas of mental health profession shortage areas. They're calculated a couple of different ways, but they're often designated by looking at psychiatrist to population ratios. And this is showing that currently we have about 4,000 mental health HIPSs designated by HRSA right now, and approximately 2,800 psychiatrists needed to address that shortage. This is an increase from 2012 of about, well, over 300 mental health HIPSs and close to 1,000 more psychiatrists needed. So we're still facing this problem of not just a numbers issue, but not having enough folks covering all communities. Primarily, these are rural communities. Many rural communities report having no practicing psychiatrists, psychologists, or social workers. So I think it's not a hard case to make that we need more and that we need more in rural areas, but how many more workers do we need? And this is really, I think, the biggest problem that we have in trying to do workforce projections is really trying to get at specifically what the need is. It's an important question because we know that mental, emotional, and behavioral disorders in youth are costly in the healthcare system. We know that youth mental health concerns have reportedly increased over time. We know that reported youth substance use has been decreasing a little bit, but we also want to keep in mind adult substance use and how that impacts children, youth, and families as well. From a workforce perspective, when we're thinking about shortage estimates, we're thinking about a couple of different factors. So certainly prevalence, but also utilization or unmet need. How do those factor into what we need our workforce to be? Unfortunately, we have little information on this at the youth level. We have better information for adults than we do for youth. But I can show you what HRSA is projecting right now. This is actually hot off the presses. It was just released last Wednesday. And what HRSA has done is take a list of selected behavioral health occupations and done supply and demand projections through 2025, and this is looking at the 2025 projections here. So you can see the occupations, they are primarily those core licensed professionals that I mentioned, again, because we have the most data on them. A new one on this list is the third one down, behavioral health physician assistants. But if you look at the supply numbers and the demand numbers and the difference in the far right column, you're seeing pretty major shortage for virtually everything except those PAs, which are showing a tiny bit of a surplus. But overall, it's looking like more than 250,000 workers needed by 2025. Now, again, this isn't including your peer providers or other non-licensed workers, and it's also not specific to children, youth, and families. But I don't think we have strong reason to believe that these numbers would look substantially better if we were able to focus down on folks providing services to that specialized population. So I just want to end with some thoughts on workforce development challenges and opportunities. Certainly recruitment and retention of workers is a challenge. This is a high turnover field, especially in the substance use disorder area. We have an aging workforce. We clearly have a need to recruit folks into rural areas. There's a need to ensure a more diverse workforce, and that came up a bit already this morning. We have a need for more specialized training for folks who are serving specialized populations. And the last point I'd want to end on is just thinking about scopes of practice. This is an area that our Workforce Research Center does quite a bit of work around. But scopes of practice can certainly enhance and limit workforce capacity. So as we're thinking through training and what folks are equipped to do and what scopes of practice may, how it may affect what's actually being done in the field, recommendations or priorities around scopes of practice may be important to keep in mind as well. That's all for me.